let's take a look at a 3 Tesla MRI using a pelvic array coil and compare it to the 1.5T comp vignette, which you'll see labeled on MRI Online. Now, this is an 81-year-old, and of course, as you get older, the incidence of low-grade cancers goes up, so it's really important to discriminate who has an aggressive cancer and who doesn't. And you're going to do that by size, by boundary crossing, by hypervascularity, but especially by the diffusion characteristics and the morphology of the lesion, whether it's crossing key boundaries or not. This patient had a negative biopsy 2 years prior to this study, and the PSA wasn't really elevated. It was hovering around 2.4. But yet the clinician felt something on physical examination, and this is the perfect patient to have an MR. You know, the clinical exam's positive, the PSA non-contributory, and the patient is 81 years of age. Patient also had a family history. So let's look at the axial T2 weighted image. And there is an area of ill-defined hypointensity in the PZL and PZP, or posterolateral and posterior aspect of the gland. And it's ill-defined with a fair amount of capsular contact. We lose to some degree the nice black line as it comes around. So we're a little concerned about microcapsular invasion. We still do see the little dots of the neurovascular bundle in the 5 o'clock and 7 o'clock position, 5 o'clock over here, 7 o'clock over here. And so we turn to our T1 weighted image. I'd prefer to have an axial T1, but I'm blessed at least with this coronal, and I'm looking at the neurovascular bundle right in the area of the tumor, so I'm scrolling backwards to that area of ill-defined character, and I really don't see any effacement of the fat on either side. I still see the veins and the neurovascular structures. That's a nerve right there. And so they're unencumbered by the tumor. So we're not going to give this patient gross invasion. There may be microcapsular invasion. Now let's turn our attention to the diffusion image, by the way, at 3 Tesla. And I'd like you to compare back and forth this 3 Tesla study with the 1.5 comp image that was a PI RADS 4 or 5, like this one, to look at the disparity in image quality, of which there really isn't any. And here is your axial diffusion image at a higher B value. Here's the low B value. Here's the higher B value. Not all that bright for this tumor. Let's go to another image at another locus. Not all that bright. I'm going to window it a little tighter. Let's go back to the one that I think is a little more impressive right there. So not as bright as I might like. Let's go to something with a slightly higher B value, a single image. And it's a little bit brighter. So why on this image with the low B value and the high B value, low B value, high B value, why wasn't it as bright? Well, the main reason was that the B value for this particular image wasn't high enough. I want the B value to be 1200 or greater. But let's talk about, for a moment, the causes for false positive and false negative diffusion imaging, because diffusion imaging is the major criteria for peripheral zone lesions. That's point 1. Point 2, causes of false positive and negative diffusion imaging, which we'll get to in a second. And point 3, you have to know what causes diffusion restriction. And what does? Hypercellularity, cell packing, necrosis, as many of us see in the brain, say with heroin encephalopathy, infarcts, like we see in the brain, with destruction or breakdown of the cell membrane where the water gets trapped in the cell, hyperviscosity, as might occur with, say, a cerebral abscess or an epidermoid, and inciting desmoplasia, where the interstitium becomes very stiff and firm. So now let's talk about item number 2 of our 3 points, which is the causes for false positive and negative diffusion. One obvious cause, the spatial resolution just isn't good enough. Typically, you're not going to get great diffusion unless you've got a lesion that's at least 5 millimeters in cubic centimeters. Mucinous tumors, fortunately they're rare, but they don't restrict. benign varicellular nodules in the TZ and sometimes proliferating into the PZ, these can restrict. So this is a cause of a false positive. So in the central region or TZ of the prostate, diffusion restriction is not a major criteria. It's a supplement. If it's positive, it helps with a suspicious morphologic lesion. If it's negative, it really doesn't help you all that much. But you can't use diffusion imaging on its own in the TZ or transitional zone. Abscesses. These are going to restrict inside where there's hyperviscosity. This is also known as the vanilla donut sign, because you've got the white vanilla in the middle on the diffusion weighted image and the solid portion of the donut around the outside. In a tumor, the diffusion restriction is more peripherally oriented. So the brighter signal is going to be on the outside, the darker signal on the diffusion, not the ADC map. On the diffusion, the brighter signal will be on the outside, the darker signal will be on the inside. So we call this the chocolate donut sign. And then, as we said, any cytotoxic or necrotic edema can diffusion restrict, and this can rarely occur in the prostate gland. Now, some other critical causes of failure to diffusion restrict. Well, one is low-grade tumor, Gleason 5 or 6. The B-value, as we said, not high enough. Got to have that B-value 1,200 or more. And then another one, perhaps the reason why this B-value did not, at 1,000, show the tumor as well. One, the B-value wasn't high enough, and two, there's air in the rectum. So air in the rectum may inhibit your ability to get a nice, crisp diffusion restriction. So let's draw these donut signs. So an abscess, we're going to have lower signal intensity around the outside on the DWI, say B1600, and on the inside where there's hyperviscosity, it's going to be bright. That's our vanilla donut sign. If we've got a tumor, it's going to be the opposite. We're going to have diffusion restriction on the outside. We're probably going to have less diffusion restriction on the inside, the so-called chocolate donut sign. And if you want to be a purist, maybe I should make the chocolate brown, because chocolate is brown. So this would be the tumor chocolate donut sign, and in the middle, this would be the abscess vanilla donut sign. Now I want to share one other thing with you on this 3 Tesla study. So let's get out of our drawing tool for a minute, and let's go to the DCE MRI, the Dynamic Contrast Enhanced MR. So let's match it up with our axial T2. Let's go right to that spot. And here's our mask. Now immediately, right after the contrast arrives, mask, contrast arrival, boom. Yes, these nodules in the middle are enhancing, very common. So you really can't use dynamic contrast enhanced MR unless you have a big charcoal-like smearing mass with very intense enhancement and very obvious washout. In the periphery, we do see as an isolated phenomenon, first 10 seconds, enhancement in the PZL lateral and PZP posterior. Let's keep going. It's getting brighter. It's getting brighter. It's getting brighter. And now it's getting a little less bright compared to the rest of the gland. So it's starting to wash out. So the curve in this one is looking something like this. Came up pretty quick, and it takes a little while, and then it starts to drop off towards the end. Now you can quantify this with a CAD, with a color map. Let's see what the color map said about it. Let's see if it picked it up. And indeed it did, right there. It also picked up these innumerable TZ central region of the gland, areas of hypervascularity, which are extremely common. So our DCE MRI said that the lesion was hypervascular, fire engine red, and that had a pretty decent washout because the hue determines the washout. So I don't rely on the hue very much in CAD for the prostate. I do rely on it in the breast. So I'm going to ignore the hue or shade of red because I don't think it's reliable. And all I'm doing is looking for hypervascularity in the PZ to see if that corroborates my tumor, but also helps me decide how vascular it is. For the more vascular it is earlier on, the more likely it is to be aggressive. The more intense the signal intensity on diffusion-weighted imaging, the quicker the rise from low B values to high B values, the more aggressive the tumor, and the more hypodense or hypointense the signal is on the ADC parametric map, the more likely the tumor is aggressive. Let's take a look at our ADC map, and here it is. Not quite as black as I would have expected, but it is present, it is there. And again, the blacker it is, the more aggressive it's going to be on the ADC map. So 3 Tesla study, posterolateral tumor. This would be a PI RADS 4/5, depending upon whether we measure it out at less than 1.5 or greater than 1.5. The reader said slightly greater than 1.5. I measured it, I got slightly less than 1.5. So I'd be reading it as a PI RADS 4. The reader read it as a PI RADS 5. This looks like a moderately aggressive lesion. Diffusion image, not that bright. ADC map, not that dark. Hypervascularity, some, in fact, moderate. Compare this to our 1.5 comp vignette. That concludes this one.